Oh, good day, dear doctors, and welcome to our last ditch uh, masterclass format for microbiology and pathology. But I'm going to deviate a little from the usual, and I'll be fusing three very important subjects, which is microbiology, pathology, and internal medicine. And the first thing I take up is going to be the biggest segment in these three books, which is from infectious diseases, after which we're going to slide on to the different systems. Now, just a few gentle reminders. Do not take pictures of the lecture. Do not video record the lecture. A recording of this session will be uploaded in a Google Drive, and you'll be given access to that after the lecture. Only take pictures of the tables or when I tell you to take a picture. Printed cram sheets will be uploaded after the session so as not to disengage you during the actual sessions. Now, these are the following references which I'll be using for this review. I'll be fusing actually 4 textbooks that will cover 3 subjects: micro, internal medicine, and pathology. Now, let's begin with the concept of the catalase, coagulase, gram-positive cocci. Now, always remember, we have the streptococci, which form strips or lines of cocci, while the staphylococci would form clusters or grape-like clusters. Now, between these two organisms, staphylococci and streptococci, which is catalase positive? Is it strep or is it staph? Okay, so the catalase positive is going to be staphylococci. Now, which is going to be catalase positive, coagulase positive? Specific species, okay, of staphylococci, which is catalase positive, coagulase positive. It's going to be Staph aureus. Very good. So the term for the staphylococci is going to be grape-like clusters. Okay, grape-like clusters. So please take note of that. Now, what if I tell you there's a grape or fruity odor? What organism produces a pigment that is grape-like or fruity odor? Okay, that's going to be Pseudomonas aeruginosa, a fruit-like or a grape-like odor. Now, what if I tell you there's grape-like mass? There's a grape-like mass in the introitus, okay? In the introitus, listen well, so you'll end up realizing your answer is 1 mile away. What do we call that grape-like mass in the introitus of a young girl? Okay. Listen well. There's no time to be careless with the examination this close. Okay. So the introitus, grape-like cluster or grape-like mass, that's going to be a botryoid sarcoma. Okay. So please take note of that. Now, this is our staph. The staphylococci, which forms clusters. Now, why are they happy? Because they have a cat. Therefore, all staphylococci are catalase positive. Okay, all staphylococci are catalase positive. Now, if you go to the textbook, okay, if you go to the textbook, I want everyone to remember that of the staphylococci species, there are 5 that can affect man: Aereus, Epidermidis, Saprophyticus, Hemolyticus, and Lugdunensis. Now, always remember, all of them are going to be coagulase negative. except Staph aureus. Okay, so please remember that. Now, where is the habitat of Staphylococcus aureus? Where is the specific habitat of Staphylococcus aureus? Okay, specific. Okay, it's the anterior nares. Okay, it is found in the anterior nares. Please be careful because the specimen collection as well as the application of medication, okay, to remove carriers of Staphylococcus aureus is up to the nares. Okay, now question, what is the drug that you will give to eradicate carriers of Staphylococcus aureus? So what is the drug that we give to eradicate? Okay, very good, very good. It is mupirocin. Okay, mupirocin. That's Bactroban. Now, what is the colony appearance of Staphylococcus aureus? What is the colony appearance? Okay, gold is correct, but we need to be more specific. So it is golden yellow colonies. Okay, the golden yellow colonies. Now, what is the name of the carotenoid pigment which is produced by Staph aureus, which is responsible for the characteristic golden color? What is the carotenoid pigment? The carotenoid pigment, which is produced by Staphylococcus aureus and is characteristic golden yellow color. Okay, that is going to be staphyloxanthine. Okay, that is staphyloxanthine. Now, if we go to Robbins, this is basically the spectrum of medical diseases which is associated with Staph aureus. It begins with a limiting food poisoning, toxic shock syndrome. It can present with a respiratory infection, osteomyelitis, skin infections, and even endocarditis. Question, what is the toxin which causes toxic shock syndrome? What is the name of the super antigen? It is toxic shock syndrome 1. Okay, TSST1. So please take note of that, TSST1. Okay, TSST1. Now, what is the name of the toxin that causes the food poisoning? What is the name of the toxin that causes food poisoning? Okay, very good. It is called enterotoxin. That's the staphylococcal enterotoxin. The staphylococcal enterotoxin. Staphylococcal enterotoxin. So please remember this. Okay. Now, what is the specific valve which is affected in endocarditis, which is associated with staph? Okay, it's usually IV drug users. It's usually IV drug users, therefore it's the tricuspid valve. Okay, it is the tricuspid valve. So please take note of that. Okay, the tricuspid valve. Okay, so I hope everyone got that. That's the tricuspid valve. Now, in the morphology boxes of Robbins, it talks about the pathogenesis of Staphylococcus aureus. What makes Staph aureus so virulent? Number one is the presence. Okay, number one is the presence, okay, of the clumping factor. Okay, the clumping factor. So this is the surface receptor for fibrinogen that is known as the clumping factor. Okay, so please take note of this. Okay, again, please take note of this. Okay, again, please take note of this. So to continue, this is part of the pathogenesis for Staph aureus. So there's actually surface receptors. Okay, there's expression of certain proteins for the surface receptors of number one, fibrinogen, and that is what we call the clumping factor. There's surface receptors for fibronectin and surface receptors for vitronectin. Now, what is the significance of these surface receptors? They are the ones that actually bind to the host endothelial cells. Okay, they bind to the host endothelial cells. So please remember that. Now here is the clumping, okay? And these are the surface receptors that you have here. Okay, just to name a few, FG, CLFA, and we also have the biofilm formation. Now, question of the different staphylococcal species, which is most associated with biofilm production? Okay, which is most commonly associated with biofilm production? Okay, it is Staphylococcus epidermidis. Okay, Staph epidermidis. Now, another entry from your mother textbook regarding the pathogenesis of Staph aureus and its virulence would be the presence of a polysaccharide capsule. Now, the reason I'm highlighting this is two reasons. Number one, most people think of strep pneumoniae when we mention the capsule. And number two, it's found in the mother textbook. So that is why I want everyone to know that. So Staph aureus actually produces a polysaccharide capsule. So what is now the importance of this polysaccharide capsule? This will aid the organism to attach to artificial materials, such as a prosthetic valve or a catheter, and this would explain why Staph aureus is associated with prosthetic valve. Okay, it's associated with prosthetic valve and catheter infections. Okay, so please take note of that. Now, question, is Staph aureus included in the common encapsulated organisms that causes an overwhelming post-splenectomy infection or OPSI? Yes or no? Is Staph aureus included in the common organisms that causes OPSI? The answer is no. Okay, the answer is no. Okay, next, another thing lifted from the mother book. For the pathogenesis of Staph aureus is the presence of the surface protein A. This surface protein A is responsible for binding to the specific Fc portion of the immunoglobulins. And once this surface protein A is bound to the immunoglobulin, It allows the organism to escape antibody-mediated killing. Now, basic immunology, what specific immunoglobulin is associated with the mucous membrane? What specific immunoglobulin is associated with the mucous membranes? It is specifically IgA. Okay, again, it is specifically IgA. It is specifically IgA. So please remember that. So where does the surface protein A of Staphylococcus aureus bind to again? Okay, let's hear it from you. Where does it bind? Okay, it is the FC. Okay, it is the FC. So please take note of that. Now, another thing you have to remember regarding Staphylococcus aureus, another thing you have to remember about Staphylococcus aureus is the hemolysis pattern on blood agar. It is beta hemolytic. We've already mentioned it's catalase positive and it is coagulase negative. So it is beta hemolytic. Question: what Lancefield classification is Staph aureus? Listen well to the question. Where does it belong in Lancefield classification? Very good. It is not included in the Lancefield classification. You might get confused because the Lancefield classification utilizes, number one, the carbohydrate, number two, the hemolysis pattern. So what is included in the Lancefield classification? If Staph aureus is not included, then what is included? Okay, perfect, very good. It is streptococci. Streptococci in general. Now, next is toxic shock syndrome, which is caused by TSST1. Now, this is the pathogenesis. I want everyone to remember this phrase. Jot this down. Super antigen-mediated cytokine storm. Okay? Jot it down so you will never forget it. So it's actually super antigen-mediated cytokine storm, as well as an M protein-mediated activation of the neutrophils. So TSST presents with shock, okay? It presents with hypotension and multi-organ damage. Multi-organ damage. Please take note of that. So that is toxic shock syndrome. Now, what do you notice here? What are the two photos that you see here? There's the presence of a strawberry tongue and the desquamating rash on the palms. Now, question, give me two other diseases that presents with a strawberry tongue. Give me two other diseases that presents with a strawberry tongue. Okay, so we have number one, scarlet fever. Number two, Kawasaki. scarlet fever, and we have Kawasaki. Okay, so please take note of that. Scarlet fever and Kawasaki. So please try to anticipate that this is syndromic. That means you're going to be given a case scenario or a clinical vignette, which would have these keywords, these key buzzwords as a case. Now, in toxic shock syndrome, this is the usual scenario. Number one, you have a menstruating woman who is utilizing tampons, okay? Or patients who have history of nasal packing for epistaxis, because tampons, like what you see here in the middle photo, can also be used for nasal packing, okay? Now, if you look in this x-ray, there is the presence of pneumatoceles. Staph aureus pneumonia is associated with a necrotizing type of pneumonia. So what is the substance? What is the substance responsible for the pneumatocele formation? Okay, it is Panton-Valentin leucocidine, or PVL. The pneumatoceles of Staph aureus is due to this substance, Panton-Valentin leucocidine, or PVL. Now, we mentioned endocarditis earlier. Always remember, Staph aureus causes acute infective endocarditis. Now, question, which has a more damaging and destructive course? Is it acute or is it subacute infective endocarditis? Okay, very good. It is acute. Okay, acute is more damaging. Acute has a more rapid deterioration and course. Now, question. In infective endocarditis, what do we call the criteria? It has major. It also has minor criteria. This is called the Duke's criteria. Okay, this is called the Duke's criteria. Now, question, what are the retinal hemorrhages that you see in acute infective endocarditis? Meron kayong retinal hemorrhages. R for retina means R for the Roth spots. Okay, and you also have a vasculitis of the palm of the hand. What is that? Palmar erythema or vasculitis, which you see in infective endocarditis. Keyword, it's the palm of the hand. In the pulp of the digits, you're going to have Janeway lesions. Okay, pulp of the digits is Janeway lesions. What about the palm of the hands? Okay, what about the palm? The pulp, okay, the pulp, I stand corrected, is Osler's. Okay, the palm is the Janeway lesions. Okay, so please take note of that. So please remember that the erythema of the pulp of the digits, that is the Osler's nodes, the erythema or the vasculitis involving the palm of the hands, this is the Janeway lesions. Now, question, what is the most prominent sign or physical exam finding of infective endocarditis? Okay. It is going to be fever. Okay, it is fever. Now, let me give you a clinical vignette. What if there's an example of someone with valvular heart disease? Let's just say he's 25 years old, he's a male, he has dental caries, and he is scheduled for a tooth extraction. Question: what prophylactic antibiotic would you give in this patient? What prophylactic antibiotic would you give in this patient? 25-year-old male with history of dental caries. He's about to undergo a tooth extraction. We would give amoxicillin. Okay, so please take note of this. So we give amoxicillin. Now, always remember the clinical scenario where you would expect acute infective endocarditis, and this is in IV drug users with involvement, of course, of the tricuspid valve. Now, tip: what is the most common cause of subacute endocarditis? What is the most common cause of subacute? Okay, it is viridans. What about acute? What about acute? Most common cause of acute endocarditis. This is going to be Staph aureus. What about intravenous or IV drug users? This is also Staph aureus. And what about those with a prosthetic valve? It's going to be Staph epidermidis. Okay, it's going to be Staph epidermidis. Now, next, we have staphylococcal scalded skin syndrome. Okay, this is, of course, caused by which toxin? Which toxin does Staph aureus produce, which causes staphylococcal scalded skin syndrome? Okay, now please take note of this. This is exfoliating. Now, question: at what specific level is the involvement of staphylococcal scalded skin syndrome? Now, let's dissect this term or this concept based on your textbook. Always remember, in staphylococcal scalded skin syndrome, there is splitting of the skin at the level of the stratum granulosum. Okay, so what is the pathogenesis here? This is how you separate yourselves from everyone else, and that is know what's in the textbook. So the exfoliating is also known as exfoliative A and B toxins. These are actually serine proteases that would cleave, take note, it cleaves the protein known as desmoglein 1. The function of desmoglein 1 is to hold epidermal cells tightly. So if desmoglein is damaged, what happens to the epidermis, the skin? There will be what phenomenon? What phenomenon would you see in SSSS? What phenomenon in the skin? This is what we call the splitting of the skin. Okay, this is the splitting of the skin. Now, don't forget the other name of staphylococcal scalded skin syndrome. Now, very beautiful description in the textbook is the sunburn-like rash. Sunburn-like rash. So please take note of this. So this sunburn-like rash is going to spread all over the entire body, and it's going to involve into bullae formation. And what's very significant here is aside from the bullae formation, there's going to be partial or total skin loss. So please take note of this. The other name of staphylococcal scalded skin syndrome is Ritter's disease. Now, question. What is the name of the disease, which is also known as Lyell's disease? What is the other name? What is the other name of Lyell's disease? Okay, very good. It's toxic epidermal necrolysis. Toxic epidermal necrolysis. So please take note of that. Okay, toxic epidermal necrolysis. So please take note of that. So the description of the rash is sunburn-like. Okay, sunburn-like rash. Very, very, very important. Now, I made a table here to compare an entry from your morphology boxes in Robbins pathology. So in the left column, we have SSSS. In the other column, we have toxic epidermal necrolysis. Ritter's disease is the most severe form of SSSS. Toxic epidermal necrolysis is also known as Lyell's disease. Now, please differentiate the desquamation level. So staphylococcal scalded skin syndrome involves granulosa or the granulosum, while toxic epidermal necrolysis involves the epidermal dermal junction. So please take note of that. Okay, so let's continue. Now, osteomyelitis in the general population, the most common cause is also Staph aureus. Now, please take note of the different organisms. So if there is going to be a sexually active individual and they develop osteomyelitis, what is now the organism? Okay, again, what is now the organism for sexually active? Okay, it's going to be Neisseria gonorrhoeae. Okay, it's going to be Neisseria gonorrhoeae. For drug users, it's going to be Pseudomonas. And for those with sickle cell anemia, it will be Salmonella. Okay, so please take note of this. Okay, Salmonella. Now, I want everyone to remember that Staph aureus is associated with a renal abscess as well as a spinal epidural abscess. Now, the spinal epidural abscess usually occurs in individuals who are diabetic. Okay. It usually occurs in those who are diabetic. Now, please take note that the most common cause of a spinal epidural abscess and suppurative intracranial phlebitis, okay, is going to be Staphylococcus aureus. Okay, so please take note of this. Still Staph aureus. Now, next, when there is a furuncle or a carbuncle, okay, this is Staph aureus. Now, what is the main difference? What is the main difference between a furuncle or a carbuncle? Which is bigger? Is it a carbuncle, okay, or is it a furuncle? Which is bigger? Okay, a carbuncle is going to be bigger. So what is the management of a carbuncle? Okay, what is the management of a carbuncle? Okay, what is the management of a carbuncle? Okay, it's going to be incision and drainage. And of course, we have the antibiotics. Okay, incision and drainage. Then we have the antibiotics. So always remember this dictum cited in Robbins that the classic staphylococcal skin infections are centered around the hair follicles. Okay, they are centered around the hair follicles. So please take note of that. Now, next is the chronic suppurative infection. Chronic suppurative infection of the apocrine glands. What do we call this condition? Chronic suppurative infection of the apocrine glands, like what you see here in the photo, which is usually the axilla. Okay. So this is hydra adenitis suppurativa. Okay. Hydra adenitis suppurativa. So please take note of that. Next, what do we call the infections of the nail beds, which is caused by Staph aureus? What do we call the infection of the nail beds, which is caused by Staph aureus? These are all lifted from the textbook. Okay, onychomycosis is actually correct in a way, but onychomycosis is usually caused by a fungus. So like what you see in this photo, okay, this is actually specifically a bacterial infection, okay? So this is paronychia, okay? But onychomycosis is it's a perfect differential diagnosis. So paronychias are specifically caused by paronychias. Okay, paronychias are specifically caused by Staph aureus. Now, what do we call this? These are all found in your textbook. Infections of the palmar side of the fingertips, like what you see here in the photo, and they are painful. What do we call the infections? What do we call the infections which are found on the palmar side of the fingertips? Okay, palmar side of the fingertips. Okay, this is what we call felons. Okay, these are felons. So please take note of this. Okay? These are called felons. Now, food poisoning that produces gastrointestinal symptoms 1 to 2 hours after eating is most likely due to what organism? So your hint here is GI symptoms, and look at the very, very short incubation period. So you should already be rationalizing here. So what is your correct answer? Is it Salmonella, Campylobacter, Clostridium, or Staph aureus? Okay, that of course is Staphylococcus aureus, which is caused by an enterotoxin. Now this enterotoxin, okay, this enterotoxin is a stable, pre-formed heat. It's a heat stable enterotoxin. So please take note of this. Now, what are the usual foods that are associated? The usual foods that are associated with staph food poisoning are going to be salads, which contain mayonnaise, like potato salad or tuna salad. And don't forget sandwiches also, sandwiches that contain mayonnaise. Okay, so please take note of this. Okay, mayonnaise. So please take note of this. So this is the classic clinical vignette, the classic scenario. Gastroenteritis, there's a preformed toxin, salads, mayonnaise. You might want to add custards to the list. Okay. Now, what if I tell you it's diarrhea from eating fried rice? Okay, diarrhea from eating fried rice. Okay, very good. This is going to be Bacillus cereus. Okay, Bacillus cereus. And what if it's diarrhea from eating shellfish and oysters? Shellfish and oysters. Listen well. I did not mention any skin infection. Okay, let me repeat. Okay, don't jump the gun yet. Diarrhea with history of eating shellfish and oysters. That would be Vibrio parahemolyticus. So what is the game changer? What is the game changer, or what will differentiate vulnificus from parahemolyticus? Okay, it is the presence of the cutaneous infection or the cellulitis. Okay, it is the cellulitis that will differentiate. Now, magic is 2 to 6 hours. Some references would use 1 to 6 hours. Your basic dictum is going to be the same. It starts quickly and it ends quickly. And the classic GI manifestations of abdominal pain, nausea, there's going to be vomiting, and there's going to be diarrhea. Okay, so please take note of this. Okay, please take note of this. What is responsible for the spectrum of disease seen in SSSS? Okay, this is an easy one. What is responsible for the spectrum of disease? Okay, very good. We, of course, have exfoliating, okay? Next, what is the most common cause of mastitis? What is the most common cause of mastitis? Okay, the most common cause of acute mastitis, okay? The most common cause of acute mastitis is going to be staph aureus. Okay, staph aureus is the most common cause. Now, what about the MRSAs? We know the MRSAs is going to come out. For the methicillin sensitive staph aureus, we give nafcillin, oxacillin, diclox. For the methicillin resistant, we give vancomycin. For the vancomycin resistant, then we give linezolid. Okay, so I'll give you a minute to go over this slide. Jot it down and stretch while you can. A clinical problem has emerged concerning infections after prosthetic heart valve insertion or other cardiac procedures with methicillin-resistant strains of, is it Staph epidermidis? Is it Serratia marcescens? Is it Streptococcus salivarius? Or is it Moraxella branhamella? Okay, correct answer here, of course, is letter A, epidermidis. Your keyword here is prosthetic. There is a prosthetic valve. Okay, again, there is a prosthetic valve. So please take note of that. Okay, there is a prosthetic valve. So I hope everyone got that. Please remember, okay, please remember that staph epidermidis is catalase positive, it's coagulase negative, but it is novobiocin sensitive. So what tests will differentiate staph epidermidis from saprophyticus? What tests would differentiate? What tests? Okay, so it's going to be novobiocin. So don't forget, novobiocin resistant is going to be saprophyticus. Novobiocin sensitive is going to be epidermidis. Okay. Now, always remember, it is the biofilm, okay, which is responsible for the virulence of staph epidermidis. So again, what is responsible for the virulence of epidermidis? It's going to be the biofilm formation. Now, please don't forget the classic clinical scenario. It's going to be associated with a prosthetic valve or the presence of a ventriculoperitoneal shunt. Treatment, of course, is the removal of a prosthetic device and giving of vancomycin. Now, what famous side effect of vancomycin should you anticipate? Okay, famous side effect of vancomycin. Okay, very good. That is red man syndrome. Okay, red man syndrome. You're gonna have the flushing. So here are the ventriculoperitoneal shunts, and there is the biofilm production. Okay. Now for saprophyticus, this is usually associated with honeymoon cystitis. Now be careful because some references also mention E. coli as honeymoon cystitis. So what is going to be the qualifier in the case or the question which would make you choose Staphylococcus saprophyticus? So it's going to be that phrase, young sexually active female. Okay. And then we have the streptococci, which is a strip of streptococci. Now, if you look at the streptococci, they are not happy. Now, why are the streptococci not happy? Because they do not have a cat. They are catalase negative. Okay, they are catalase negative. Now, what do we call this classification? The serologic classification along with the hemolysis pattern. Okay, this is known as the Lancefield classification. Now, tip. Always remember what is the hemolysis pattern. We have beta, okay, the following: pyogenes and agalactiae. The anginosus, you don't have to memorize that. The dysgalactiae, you don't have to memorize that. The alpha is going to be viridans, pneumoniae, okay, and bovis. Question: which streptococci is associated with colon carcinoma? Which streptococci is associated with colon carcinoma? Okay, very good. Streptococcus bovis is associated with colon carcinoma. Okay, Streptococcus bovis is associated with colon carcinoma. Streptococcus bovis. For the streptococci, I strongly encourage you to be aware of the different hemolysis patterns. Beta is complete, alpha is partial, gamma is no hemolysis. Okay. Please take note of that. Beta hemolysis, that's complete hemolysis or a complete zone of inhibition. Alpha is partial. Gamma is no hemolysis. So please take note of that. Now, if you remember strep pneumoniae, it is encapsulated. Okay. I want everyone to remember encapsulated organisms. Strep pneumoniae, the capsule is identified with performing the Kilong reaction. So this will differentiate strep pneumoniae from the other organisms. So question, what is the positive reaction for Kilong reaction? What is the positive reaction for Kilong? Okay, it's going to be capsular swelling. Okay, the capsular swelling. So please take note of that. Capsular swelling. Now, don't forget, Streptococcus pneumoniae also has IgA protease. This also increases its virulence. And of course, we have the most common cause of lobar pneumonia, that is strep pneumoniae. Now, what if it is ventilator-associated or hospital-acquired pneumonia? What is the organism? Ventilator-associated or hospital-acquired pneumonia. What is the most common organism? Okay, this is now going to be Pseudomonas. Okay, this is now going to be Pseudomonas aeruginosa. So please take note of that, Pseudomonas. What if I tell you it's a pneumonia which is associated with the fleur-de-lis pattern? What is fleur-de-lis pattern? Okay, it is still Pseudomonas aeruginosa. What if you're dealing with a pneumonia, which is known as the walking pneumonia? The walking pneumonia, the best answer is still Mycoplasma. The best answer for walking pneumonia is Mycoplasma. Now, what if I tell you this is associated with a bird handler? What pneumonia is associated with a bird handler? Okay, this is now Chlamydia psittacasi. Okay, that is Chlamydia psittacasi. What if I tell you this is an HIV positive individual and they develop pneumonia? What is the most common etiology? Okay, this now becomes Pneumocystis jerovecii. That's your Pneumocystis jerovecii, okay, which is also referred to as Pneumocystis carinii pneumonia. Pneumocystis carinii pneumonia. So please take note of that. Pneumocystis carinii pneumonia. So these are the diseases. Okay, these are the diseases which strep pneumoniae causes: community-acquired pneumonia, meningitis, otitis, sinusitis, spontaneous peritonitis in children, and sepsis in children. with sickle cell disease. So please remember this, okay? Sickle cell disease, very, very important. Okay, so please pay attention, particularly for the community-acquired pneumonia, particularly if you hear the phrase lobar pneumonia, and if you hear the phrase rusty sputum. Otitis media, which you might encounter the phrase luga. And of course, sickle cell anemia sepsis. Now for pyogenes, I just want to highlight pyogenes. This is beta hemolytic. This is bacitracin sensitive. It is also positive for the PYR test. Okay, it's PYR positive. Now, when you hear pyogenes, always think of rheumatic fever and always think of glomerulonephritis. Now, these are the most common infections. So this is a summary of the infections, which is caused by strep pyogenes. We've mentioned already the pharyngitis or the sore throat. Scarlet fever is there for the skin infections. Okay, this would include impetigo as well as folliculitis and cellulitis. Now be careful because folliculitis and cellulitis can also be caused by staph. However, impetigo can also be caused by staph. But if they use the term honey crusted lesions, okay, honey crusted lesions, I want you guys to take note of impetigo. Okay, please take note of that. Impetigo. Okay, again, please take note of that. Honey crusted. Now, here is the classic strep pyogenes infection. Here's the classic skin infection. And don't forget 3 very important antibodies. We have the ASO, or the anti-streptolysin O, which would document an antecedent pharyngitis or throat infection. Anti-DNase, which would document an antecedent skin infection. And of course, we have a drug which has been developed from the streptococci itself. This is anti-streptokinase. So this is used as a clot buster or a thrombolytic for myocardial infarction. Please take note of this. It's streptokinase. So don't forget, scarlet fever and Kawasaki disease would present with the strawberry tongue. Now, which of these two diseases would present with a rash? Listen well to my question. Which of these two diseases would present with a rash? Okay, which of these two diseases would present with a rash? Is it scarlet or is it Kawasaki? Ooh, be careful. Why? Doesn't Kawasaki present with a rash? Does Kawasaki present with a rash? Yes or no? The answer is yes. So both scarlet fever and Kawasaki will present with a rash. So don't forget, Kawasaki is a mucocutaneous lymphadenopathy. Okay, mucocutaneous. It's unilateral lymphadenopathy. So treatment-wise, scarlet fever, you give antibiotics. Kawasaki, what is the treatment for Kawasaki? Okay, drug of choice. Ano yung drug of choice for Kawasaki? Listen to the question well. The drug of choice is not aspirin. The drug of choice is IVIG. When and why do we give aspirin? When and why do we give aspirin? We give aspirin to prevent the complications, which is coronary artery disease, as well as the aneurysm. That is the reason why we give aspirin. It is not for the treatment. Please remember that it is not for the treatment. Okay. Now, don't forget the rash, okay, of scarlet fever. So we have the famous boiled lobster appearance. Okay, the boiled lobster appearance. Okay. What is the other description of the rash? Very good. It is the sandpaper rash. Okay, the sandpaper rash. Now for the treatment, I want you guys to anticipate the treatment. Okay. So for the treatment, for classic streptococcal infections, it's still going to be penicillin. Okay, it is still going to be penicillin. If there's allergies, then of course, then we can give erythromycin. Okay, if there is allergies, we can give erythromycin. Now, question. What is the most common cause of neonatal meningitis? The most common cause of neonatal meningitis. Okay, so neonatal meningitis is usually caused by either uh, Strep agalactiae, Listeria, or E. coli. But I want everyone to memorize Strep agalactiae. It causes neonatal pneumonia. It causes neonatal sepsis. It causes neonatal meningitis. Okay, so please take note of this. So don't forget, okay, your visual mnemonics for Strep agalactiae. Your visual mnemonics for Strep agalactiae is it is group B strep. What is the meaning of letter B for group B? Let's see if you're still with me. What is the meaning of letter B? Okay, B means vagina, and it also means baby, which is bata. Okay, Strep agalactiae, sakit yan sa bata. Okay, now treatment, we still give penicillin. Okay, basta gram positive, okay, we give penicillin. Okay, basta gram positive. If it is serious, especially for neonates, then we give aminoglycosides. Okay, so we give aminoglycosides if it's a serious infection. Okay, so always remember, first line is penicillin. Okay, let's emphasize that. First line is penicillin. We add aminoglycosides if it is a serious infection or the child is septic. Okay. Please take note of this. Okay. Now, I want everyone to remember when it comes to dental caries, what is the streptococci aside from viridans, which is notorious for causing dental caries? Okay, it is Streptococcus mutans. What is that specific enzyme that Streptococcus mutans has, which would destroy the enamel? Okay, very, very good. Okay, it's dextran ducrase. Okay, dextran, ducrase. So please take note of that. Okay, dextrans, ducrase. So I hope you got that. Okay, that is for Streptococcus mutans. Now, please take note of Corynebacterium diphtheriae. Very, very important in Corynebacterium diphtheriae is its morphology. It is Chinese character. Now, yung club shape, I honestly would not memorize this because club shape is not very specific, but the Chinese character is very specific. Okay. Now, it is catalase positive. It uses this famous medium, which is the Loeffler's medium. Now, please don't forget the Babes Earns granules. Does anyone here know what are the other names of the Babes Earns granules? They are also called metachromatic granules. They are also called the volutin granules. So please make sure you know this. Metachromatic and the volutin. So always remember, okay? Always remember that you are already in the last phase of your review, okay? Things should already be familiar and you are here to finally master things. So you have the famous pharyngeal pseudomembrane. You have complications of diphtheria, which is going to be myocarditis. It also affects the nervous system. And you have here the diphtheria toxin. Now, what is so unique about the diphtheria toxin and the inhibition of protein synthesis? Okay. What is very important and unique? Okay, so we basically have, we have what we call the inhibition, okay, of elongation factor 2. Okay, now what is the other organism? What is the other organism which also inhibits elongation factor 2? Okay, a very important organism. It's Pseudomonas. Okay, Pseudomonas. So please make sure you have this. So for the treatment, it's still going to be erythromycin. And for exposure of contacts, it's also going to be erythromycin. So please take note of that. So here is these are the keywords. So you have a pseudomembrane. Okay. Now what do we call the classic lymphadenopathy. So it's going to be called the bull neck. Okay, it's called the bull neck. Okay, the bull neck. Now, what is the most common cause of myocarditis? Give me the organism. Most common cause. Okay, most common cause is going to be Coxsackie B. Okay, Coxsackie B. Now, give me the etiologic agent for whooping cough. What is the etiologic agent? Okay, agent. Do not give me the disease. Give me the agent. It's Bordetella. Okay. And what is the most infective stage? What is the most infective stage? This disease has 3 stages, which is the most infective. Okay. Scatteral. So please take note of that. Now next, so here, that's your grayish pseudomembrane there. Careful because it might bleed, might cause asphyxiation. And what do we call the test for immunogenicity and toxigenicity? So don't forget, we have the ELIC test. Okay, this is the immunodiffusion technique. So the ELIC test is the immunodiffusion technique. This is used to test for the toxigenicity. Okay, ELIC. Can anyone tell me what the other test is? What is the name of the other test? Okay, very good. It's the Schick. So what is the Schick test? Okay, so always remember, ELIX is toxigenicity, while Schick, letter S, is letter S, susceptibility. Okay. So letter S for Schick, this is susceptibility. And we have ELIX, which is for toxigenicity. So please take note of this. Now, give me your diagnosis if you have a patient with opisthotonus. Okay, this is, of course, tetanus. What is the etiologic agent for tetanus? This is, of course, Clostridium tetani. Okay, this is Clostridium tetani. Okay, so please take note of that, Clostridium tetani. Now, what are the 2 toxins produced by this organism? Okay, so we have glycine, then we have gamma amino butyric acid or GABA. Now, what is similar to glycine and GABA? Unsang nakapareho? Ano yung bakit nagkatulad yung dalawa? Okay, both are inhibitory. Okay. What's the classic grin? What is the classic description? What's the classic description of the grin? Okay, this is the famous sardonic grin. Okay, the famous sardonic grin. Okay. So please take note of this, the sardonic grin or the rhizus sardonicus. Okay. Now, as for the treatment. Okay, I want you guys to remember you are supposed to give what drug? What drug are you supposed to give for the treatment? Okay, very good. It should be metronidazole. Okay, treatment is metronidazole. Okay, metronidazole. So we have here the trismus, which is the locked jaw. Okay, the trismus, which is the locked jaw. Okay. This rhizosardonicus, which we consider as the smile of death. Okay, here's the trismus. Okay, does anyone understand or can explain why the pathology is trismus and not the other facial muscles? Would anyone happen to know why? The explanation is actually the masseter. The masseter muscle is most sensitive to the toxin. Okay, now we usually suggest a tracheostomy because respiratory failure is usually what's encountered. Okay, respiratory failure is what is usually encountered. So here, I want everyone to remember the treatment. So for the treatment, do not forget it is metronidazole. Okay, for the treatment, it is metronidazole, and it is not penicillin. Okay, penicillin will actually potentiate GABA. And part of the treatment, of course, is the passive immunization. Then we also give the tetanus toxoid. Okay. So as to the giving, it would depend on the vaccination history of the patient. Okay. It would depend on the vaccination history of the patient. Please remember this. The next, we have here the famous Clostridium perfringens, which is, of course, associated with a characteristic double zone of hemolysis. This is the toxin everyone has to memorize, lecithinase. I want you to memorize lecithinase. Now, there's also the famous Nagler reaction. Okay, so treatment here would be penicillin. You can add clindamycin as well. Now, my question is very, very simple. What actually is this Nagler reaction? Okay, what is the significance? Okay, what is the significance of the Nagler reaction? This is specific for Clostridium perfringens. This is going to test for the production of the toxin. Okay, it's going to test for the production and presence of the toxin, which is particularly the alpha toxin. Okay. Now you might hear the term gas gangrene. Okay, so don't forget the term gas gangrene. So take note of that. So gas gangrene. Don't forget the alpha toxin. That's the classic case you're going to get. Then you might also get another case, vignette, which is the presence of skin crepitations and the presence of a gangrenous wound. The skin crepitations and the presence of a gangrenous wound. Now, question, what is the management aside from dipredma and antibiotics? What is the management specifically for Clostridium perfringens? Okay, very good. It's the presence of the hyperbaric oxygen. Okay, hyperbaric oxygen. Okay, very, very important. Hyperbaric oxygen. Here's a photo of a gangrenous wound. Don't forget the term gas gangrene. Okay. Now, answer this. Which of the following is the most potent exotoxin known? Is it botulinum? Is it erythrogenic? Is it tetanospasmin? Or is it alpha toxin? So the most potent exotoxin known is botulinum toxin. Okay. So is this botulinum toxin A or botulinum toxin B? What is the most important botulinum toxin? Is it toxin A or is it toxin B? Now, it is usually toxin A, okay, which is important. And it's also the one used for cosmetics. Now, Clostridium botulinum is associated with food poisoning, okay? It's also associated with what we call the floppy baby syndrome. This is the infant botulism. Okay, floppy baby syndrome. Okay, the floppy baby syndrome. So this is associated with ingestion of what food product? It's particularly honey. Okay, it is particularly honey. That is very, very important. Okay. So don't forget floppy baby syndrome, botulism. Don't forget its association with honey and improperly canned foods. Okay. Improperly canned foods. Now, it also presents with ptosis and muscle weakness, facial weakness. So, question, what is your differential diagnosis here? Ptosis and facial weakness. What would be your differential diagnosis? Okay, very good. Differential diagnosis here would, of course, be myasthenia gravis. Okay, myasthenia gravis as a differential diagnosis. Please take note of that. MG. Okay, so please don't forget that. Now, what about Clostridium difficile? Okay, what is the classic picture of Clostridium difficile? This is associated with pseudomembranous colitis. Now, one of your complications of pseudomembranous colitis is the toxic megacolon. Now, Clostridium difficile is usually associated with antibiotics. What are the most common antibiotics associated with Clostridium difficile infection? It would put clindamycin on top of the list, cephalosporins, okay, clindamycin, cephalosporins, quinolones, okay, as well as ampicillin. Okay, so please take note of those four. I want everyone to take note. We are dealing with either clindamycin, cephalosporins, okay, clindamycin, cephalosporins, as well as ampicillin. Okay, so please take note of that. Hope you got that. Now, most sensitive here is stool culture. Okay, the most sensitive here is stool culture. Colonoscopy, everything else will just be confirmatory, but that is not the gold standard. The gold standard is really stool culture. And if you do an immunoassay, okay, that is going to be very, very helpful. Now, treatment. What is the treatment for mild pseudomembranous colitis? Okay, mild is treated with metron. What about for moderate to severe? Moderate to severe, we treat using Vanco. Okay, we treat using vancomycin.